Good morning. This is Dr. Babak, Larian, and I am doing a Facebook Live question and answer session for parotid disease and disorders. And I'm happy to be here answering any questions, especially during this time with COVID that people have poor access to healthcare. And this way I can answer questions from anybody around the world and hopefully help them out and guide them. So this is an amazing platform for that during this time, and anytime actually. In any case, let me start by answering a question by a patient whose name I don't know. This is an Instagram question, so here we go. She's asking, is it possible for benign tumors to come back once they are removed? What is the percentage rate of getting paralysis after parotid tumor removal? How long does the recovery take? What are the pre and post surgery precautions? How painful is it? I have tons of questions, doctor. I already have an appointment with you, but can't wait to ask all of this. I'd love to have the link in these comments, please, cause I couldn't find it on your bio last time. Thanks. Okay, here we go. So let me actually go over the surgery first, and then that way I can explain the chance of coming back, the recovery, and all sorts of other issues involved, okay? So here we go. Let me flip the camera. There we go. Okay. So this is the parotid gland, and you can see the tumor developing inside the parotid gland, right? So the gland is right there, right? And the tumor, as you can see, is developing in it. When you do a cross-section of the parotid gland, it looks like this, right? And the nerve is in the deeper portion of the gland here, right? And most of the parotid is superficial, and a little portion of it is deep to the nerve. So we say 4/5 is superficial and 1/5 deep to the nerve. In the back part, in the area behind the jaw. Now, if you do a cross-section of the parotid there, the parotid thins out over the jaw, and at this point, there are multiple branches of the facial nerve, right? So let me actually redo this without the tumor on there. Okay, so the facial nerve comes out of the skull, enters the parotid gland, divides into two branches, the upper branch and the lower branch. The lower branch goes to the lower lip and neck muscles. The upper branch goes to the upper lip, smile muscles, eye, and forehead, right? So when you look at this area, right, actually where the tumor is, so when you look at that area where the tumor is appearing in this picture, again, redoing it multiple times. But here's the facial nerve coming into the parotid gland, dividing into a lower branch and the upper branch, right? And again, when you look at the cross-section here behind the jaw versus the cross-section here in front of the jaw, behind the jaw, the parotid is thick. The facial nerve is in the deeper portion. Here, in site number 2, the parotid gland flattens out, becomes very thin, and you have multiple branches there. So the surgery that you do is a little bit different in different areas because of the amount of parotid tissue that's in that area and the amount of involvement and the number of branches that are present in that area. So typically, most of the parotid tumors happen in this portion behind the jaw, right? So this is the jawbone, right? Most of the tumors happen, I'll draw it in green, in this area of the parotid, because this area of the parotid is thick, like that. And there's more real estate for tumors to occur. There's more tissue available for things to develop, right? So when we do the surgery, the first task at hand is to find the nerve branches, right? And remove the nerve. So again, let's look at this. So if you have a tumor, a smaller size tumor like this, if you were to look at the nerve branches, right? And if the nerve branches happen to come down and be a little distant away from the tumor, then when you take out the tumor, you can take a little margin of normal parotid all around, and also here, when you're close to the nerve, you still have a little bit of a separation there, okay? On the other hand, if the nerve comes out and it's sitting exactly on the tumor, then when you're trying to take it off, you can have margins in this area, but when you get to the nerve, you're going to be sitting right on the nerve, right? So when you don't have enough space between the nerve and the tumor to get an additional margin, there is a little bit of a higher chance that those tiny little legs that the tumor has may be amputated during surgery. So by that I mean, I'm going to draw the tumor, I'm going to draw it in red here. So when you amplify pleomorphic adenomas and under the microscope you look at them, instead of looking perfectly round like this, they actually look like so there are studies that show, studies where they took pleomorphic adenomas and looked at them under the microscope, and they show that anywhere between 4% to 30% of the tumor is covered by these legs, right? So fortunately, it's not 100%, it's not the majority. And if the nerve happens to be just adjacent to this area where there's no leg, then they're okay. But if it happens to be right next to this area where all these little legs are, then there's a possibility that when you do surgery, right, when you do surgery on a nerve that's here and you get close, you're not amputating those little legs. But if you do surgery on an area where the legs are sitting right next to it, you may amputate the microscopic leg without realizing it and leave a piece behind, which means in time this little piece can grow and recur, right? At least that was our concept and understanding. Having said that, I'd say at least 80 to 90% of the tumors that I do surgery on are sitting on the nerve, on a branch of the nerve, right? So I'll always have to get close in those areas. And despite that, the recurrence rate for these tumors is exceedingly low. The literature says anywhere between 2 to 3% of the times. In my experience, in the past 18 years that I've been doing this, I've had only 2 patients have recurrence, right? And I do anywhere between 2 to 5 surgeries, parotid surgeries a week. So the recurrence rate has been very low, right? And I think the reason for that is that you have to be meticulous. You have to take your time. This surgery cannot be a rush. It has to be something that you take your time on and really pay attention to, right? The more you pay attention to it, the better the results the patients will have. And we do the surgery under microscopic magnification. We wear these lenses during surgery. The lenses that I wear magnifies everything 3.5 times. So I see it magnified. I can focus more on my surgery, on the tumor removal. Most parotid surgeons do the same, and therefore they can do a better job. Being meticulous is really the key. Being for a lack of a better word, anal retentive, right? You very neurotic and precise is the way to do the surgery properly, right? Not compromising on anything and preserving every nerve branch possible, right? Because it is a benign tumor, right? You're not going to sacrifice a nerve branch for a benign tumor, right? Okay, so that's really the key to doing a good job with the surgery. Now, pleomorphic adenomas in cancers have little legs. Other benign tumors do not. So the concern for recurrence is significantly lower for other types of benign tumors in the parotid gland or salivary glands besides pleomorphic adenomas, okay? Now, going back to the image again. Now, despite, again, having these close margins, 90% of the time, the recurrence rate is low. And the reason for that is that most likely, when you have experience and you get close here to the nerve, and if you get on the nerve and dissect the nerve off the tumor, right, then you're not cutting those legs first. So the experience of the surgeon matters, right? And I also find that under microscope, when you look at these tumors, there's a lot of immune reaction to them, right? It's very common to find lymphoid tissue or white blood cells in the tumor itself, in this area surrounding it. So pleomorphic adenomas really activate your immune system to try to attack and take care of it. And I think if small microscopic amounts are left here at the nerve, probably the immune system is working to get rid of it, okay? So again, being meticulous and making sure you minimize as much as possible the amount of tumor that potentially is left behind microscopically is the key to success, because then the immune system has an opportunity to overcome it. Fortunately, our body is designed to have a very strong immune system. We're fighting infections and tumors on a daily basis, right? So now, I think what causes most of the recurrences of pleomorphic adenomas is rupture. So let me explain. When you look at the surface of pleomorphic adenomas, so let's say again, this is the pleomorphic adenoma tumor. The tumor has a capsule, right? And the capsule can be thin, it can be thick, right? But it also has gaps in it. And that gap is the area where the little legs bulge out of, right? That's just the nature of pleomorphic adenomas. It's very odd, okay? And if during your surgery, as the surgeon is holding on to the tumor and pushing it away from the nerve, if the tumor ruptures, right? So if the tumor is being pulled and this portion of it pulls away, right? So all of a sudden you get this black part being pulled away and the tumor ruptures, you can have spillage of tumor all around. That really is the reason, I believe, for most of the recurrences, right? And there are ways to address that when that happens. It's very important. Again, the experience of your surgeon is important. You have to wash the field with lots of fluid. and any area adjacent to it, you have to cauterize so that if any potential cells are there, you cauterize it. Obviously, you won't cauterize the nerve that's close to it, but there's ways of addressing rupture. Rupture, unfortunately, does happen in a very small percentage of cases, and you know, it has to do with the nature of it. If you have a tumor that has only 4% areas of breach in it, right? Less likely, but if you have a tumor that's more 30% breach, right, then it's more likely for a rupture to happen. So you have to do the surgery assuming that most tumors are at 30%, so that you are more meticulous, more cautious with the tumor, and you do a better job and then make it less likely to get rupture, right? So the incidence of recurrence is, again, reported in the literature to be 3%. In my experience, it's significantly lower than that, and that probably is because of being meticulous, neurotic, and attentive during surgery. In terms of paralysis, in the literature, again, they quote a less than 1% chance of paralysis. To prevent paralysis, what we do during surgery is we put probes in the upper and lower, and sometimes even 4 separate areas into the muscle. And by putting a probe into the muscle detects any kind of activity in the nerve, so that if you are doing surgery, right, and you find the nerve right here as it's entering the parotid gland, and you carefully dissect it out and separate it, the closer you get to the nerve, the more likely it is for these branches to give you some sort of electric signal. So you have one measure of safety, besides understanding anatomy and knowing the anatomy, is to also pay attention to the nerve monitoring device you have in surgery. Another technique that we use to address this is also to stimulate the nerves. During surgery, we use the nerve stimulator. We stimulate this part of the nerve with a small amount of electricity, and we see movement of the muscles in all these areas, right? And that way you can test and say, okay, is this a blood vessel here that I'm dealing with? Is it scar or is it nerve? And you stimulate it, and by stimulation you get activity. You know that you're doing the right thing, that what you have is the nerve. So there's many different layers of protection for the nerve, many different layers of trying to find the nerve and seeing where it is and addressing it appropriately, okay? And those are all important. And again, the more experienced your surgeon is, the more they know how to do this, and the more they've seen these different issues, so they're better able to address it, okay? So in terms of nerve paralysis, the chance of nerve paralysis is significantly lower than 1%. It has to do with the experience of the surgeon, so the more of these surgeries they do, the less likely it is for them to have nerve paralysis. It also has to do with a tumor, the relationship of the tumor. So if the tumor is away from the nerve, like we see here, we'll draw the tumor in black, then less likely to have issues. If the tumor is underneath multiple branches, right, and it's big, let's say, so if the tumor is like this, underneath multiple branches, then obviously a more challenging surgery, because you have to find the branches of the nerve, dissect them out, and then push them over and take the tumor from underneath. And then if the tumor is wrapped around the nerve, which is less likely with small benign tumors and more often occurs in cancers, if the tumor is just wrapped around the nerve, then you have to open the tumor, take the branches out, and then remove the tumor from around it. So the risks are different based on the relationship of the tumor to the nerve. Fortunately, benign tumors are very unlikely to wrap around the nerve. They can be next to the nerve, or they can push the nerve, or they can be underneath it, but they're unlikely to wrap around the nerve and involve the nerve in that way. Okay, so the incidence of nerve injury is significantly lower in benign tumors. Now, there's two ways of doing prodigectomy. One is the standard what we call a superficial prodigectomy, where both the tumor and the entire parotid gland that's superficial to the nerve branches is removed. That's a superficial prodigectomy, right? Another way to do it is to remove the tumor, find all the nerve branches, right? Find all the nerve branches and remove, once you've found the branches, remove the tumor and a margin around it. And one other way that can be done is, instead of finding the nerve all the way up there and tracking it out, okay, this what I just described is partial prodigectomy. And the last way is called an extracapsular dissection, where what you do is you find the nerve branches, right, that are, you track out the nerve branches that are immediately close to the tumor. You don't go looking for other ones that are further away, right? The ones that are immediately close you find, right? The rest you leave alone. And then you remove this is called extracapsular dissection. This dissects the nerve out a lot less and only in the area close to the tumor. And this decreases the risk of injury to the nerve even more. But not every tumor is an appropriate candidate for this surgery. Not every patient is an appropriate candidate. In primary tumors that are less than 4 centimeters, that the tumor is mobile, benign, and in a way that's amenable to this procedure, it can be done that way. And that's a very good way to approach some of the smaller tumors with an extracapsular dissection, which means you're taking out less parotid, you're exposing the facial nerve less, so you have less risk, an easier reconstruction, and an easier recovery. So the recovery from this surgery is dependent on that. Now, the recovery from prodigectomy is fortunately not too challenging. This is an outpatient procedure, the way I do it at least. Everybody goes home the same day. Majority of patients don't have a drain. Some do, depending on the amount of tumor, the tissue that's removed, and the type of reconstruction that's done. And so everybody comes out with a wrap around their head to put pressure, so the skin that was lifted off the parotid gland that's now being laid back on is pushed onto the gland so they can stick together pretty quickly, right? So you have a pressure dressing on, a wrap, like one of those old dental wraps, but a Velcro version of it, right? It's easier to use. And then all the sutures that we do for the R incision, which is just around the ear. I don't use an incision that goes in the neck. The incision that's here, and most of the time it's just in front of the real earlobe and then goes behind in the groove behind the ear. All the sutures are under the surface and absorbable. And so there's no suture removal, right? And so again, the surgery is outpatient. You come, you have the surgery, you go home the same day. You're able to eat, talk, walk immediately after surgery. The only limitation is that you're not supposed to have spicy or sour foods for 2 weeks, but you can have regular foods as of the next morning. The first 24 hours, I would suggest that people have bland foods so they don't get nauseated from the surgery. But as of the next day, regular diet, just not spicy or sour for 2 weeks. and you can resume regular exercise 3 weeks after surgery. And that 3 weeks after surgery is mainly for blood vessels to heal and close up, so that if you increase your blood pressure during surgery, you're not popping open a blood vessel in a sense, right? And fortunately, in all the years that I've been doing this, we haven't had any kind of complication like that at all. When there's more extensive surgery, sometimes we ask the patients to wait longer to do surgery, to do exercise, but in the majority of cases, 3 weeks is enough. I'd say most people are able to get back to work at 1 week, right? They still will have a little bit of swelling that they notice themselves after the first week. By the end of the second week, the swelling is so down that most people won't even notice it, right? Except you yourself, of course. Let's see. This is not a very painful surgery because, let me show you why. Again, let me bring you down here. The nerve that goes to the earlobe is a different nerve from the facial nerve. So the facial nerve again comes like this. The nerve that's in charge of your sensation of the earlobe comes from your neck up and gives branches to the earlobe and the skin here. So the lower part of your ear and a circle around here is based on this nerve that's immediately under the skin. During the surgery, I find this nerve, dissect it out, and I push it out of the way. So I push it like this out of the way, right? So it's that way I can do the rest of the surgery, right? By pushing it out of the way, I preserve the nerve, and a month after surgery, a month and a half, the sensation for the earlobe, it comes back. The good thing about preserving the nerve, obviously, is that the sensation comes back. And the real good thing with it is that by pushing the nerve out of the way, it causes it to not work for about a month, month and a half, which means you have numbness in this area for a month, month and a half, which means you have numbness in the area of the surgery. It's as if you have a local anesthetic preventing you from feeling that area and having pain. And that's really helpful. So I'd say probably close to 50% of my patients don't actually take too heavy pain medications. Tylenol is enough to do the job, right? And the other 50% take the pain medications that anywhere between 2 to 3 days, or maybe even up to 5 days, okay? And that's generally the way. So the recovery is not too difficult. It's just onerous because you have to have a wrap around your head, putting pressure so that the area of the surgery has minimal swelling and all the layers heal quicker, right? That's the burdensome part of it. That's it. That, I think, answers those questions. Miss Sean Baby 19 is asking, what is the average cost of microprodigectomy? You know, first, I'm only a doctor, so I don't know the financials so well. But if you actually send your information to the office, then I can look at it and see how extensive of a surgery you need, and then I can let my staff know to figure out the financials involved. Because we also have to figure out, you're writing if you have minimal insurance coverage, what your insurance will do for the operating room, anesthesiologist, and all those things. And we can figure all that out for you and take care of it. Let's see. Jordan is asking, I have a lump underneath my ear. Is there any way to reduce this without surgery? Jordan, it really depends on what this lump is, right? If it's in the parotid gland, then no, surgery is the only way, unless this is a cyst, which is a fluid-filled sac, in which case we can try to draw the fluid out and see if the fluid reaccumulates. Majority of times it does reaccumulate. Sometimes we're lucky, and when we take the fluid out, it doesn't reaccumulate, and then you end up being okay. So I would need more information to be able to answer your question appropriately. All right, and then Amber is asking, how long can a swelling last after surgery? Well, in terms of parotid surgery, the swelling, obvious swelling for 1 to 2 weeks, but you yourself as a patient will see the swelling for probably 2-3 months, that you'll notice yourself there is some degree of swelling, and then it'll take time to come down. And for some people, it really gets to the final way it's gonna look at about 6 months, but those are subtle changes after the first month, okay? Oh, actually, Amber is asking after sublingual glands, so there's salivary glands under the tongue, after removal. Well, Amber, it really has to do with how big the mass in the sublingual gland area is. I believe you had a ranula, which is a fluid-filled sac of saliva gland, and it depends on the size. If the size is really massively big, then the swelling can last 2-3 weeks and up to 2-3 months. Again, it just really depends on how big the lesion is. Anyways, I hope you found this helpful, and I hope this helps you along the way. If there's any further questions, don't hesitate to let me know. Have a wonderful day. Best of luck with everything. Bye-bye now.